You know, as an anesthesiologist, we are concerned with cardiovascular monitoring and stabilization, hemodynamic stability, and respiratory management. For that, if we have a cardiac monitoring during our perioperative, preoperative, and postoperative, it will be good. So one must know about monitoring primarily for management of cases. Simply, a non-invasive monitoring has come up, but now we have to do in certain difficult cases invasive monitoring, which include arterial, venous, and other which is required. So Dr. Manpreet will talk about monitoring, invasive monitoring. Go ahead with that. Dr. Manpreet, she's associate professor at AIMS. She has a visiting faculty in Penn State, Milton, Pennsylvania, USA. She has a special interest in pediatric anesthesia, trauma, and simulation. She has almost 15 years of experience. Now, I request Manpreet Kaur to continue her talk.
I'll be talking about invasive monitoring, which includes intra-arterial blood pressure monitoring and CVP monitoring. Coming to A-line, the arterial cannulation with the continuous pressure transduction remains the accepted reference standard for blood pressure monitoring, despite its risks, costs, and need for technical expertise for placement and management. It provides a continuous real-time monitoring, especially in major surgeries where you would like to have beat-to-beat monitoring of the blood pressure. In patients with significant comorbidities, whether cardiovascular or respiratory, in critically ill patients who require the titrated vasoactive medications, and in patients where non-invasive blood pressure measurements are difficult, like in Burns cases. The arterial pressure waveform characteristics are used in the current clinical practice, which include the dicrotic notch as a trigger for intra-aortic balloon counterpulsation, as well as the respiratory induced variation in the arterial pressure waveform to predict the fluid responsiveness, that is, the dynamic assessment of the fluid responsiveness. And despite the list of contraindications, there is less than 1% chance for major complication with arterial cannulation. A risk to benefit analysis should be performed in each patient prior to proceeding with the arterial cannulation. The few contraindications include either there is the absence of the pulse at the anatomical location site of the artery, or the peripheral vascular disease with Raynaud's and Berger's, and relative being coagulopathy. The radial artery is the most common site for invasive blood pressure monitoring because it's technically easy to cannulate and the complications are rare. The most frequent location for radial artery cannulation is at the proximal flexor crease of the wrist, 1 centimeter proximal to the styloid process. The ulnar artery has also been used safely even following failed attempts to access the ipsilateral radial artery. The more central vessels like femoral, brachial, and axillary artery, they are as well used for cannulation. The axillary artery has advantage of patient's comfort and mobility, and complications appear to be similar in incidence to the radial and femoral. For the femoral cannulation, the access site is around 2.5 centimeter distal to the inguinal ligament. This allows for suitable compression of the vesicle if necessary. Whenever you're planning to put in central catheters, we need a slightly longer catheter due to their relatively deeper and more mobile anatomical locations. Clinicians should also be aware, however, that there is risk of cerebral embolism with these central vessels compared to the peripheral vessels. Coming to the radial artery, for the radial artery cannulation, some clinicians assess collateral blood flow to the hand by performing a modified Allen's test. The radial and the ulnar arteries, they are both compressed while the patient makes a fist to accentuate the palm and then slowly reopen it. As the occlusion of the ulnar artery is released, the color will return to the PAM within 5 to 10 seconds, whereas in severely reduced collateral flow, that will take more than 5 to 10 seconds for the blood supply to return. Unfortunately, the predictive value of this test is very poor. The equipment: a 20 gauge catheter is acceptable size for older children and adults, and a 22 gauge is used in pediatrics and infants. When planning for brachial or femoral artery catheter cannulation, appropriate length catheters are necessary to ensure sufficient cannulation. For example, in brachial and femoral, you'll be needing at least 15 centimeter to the minimum. Preformed kits are as well now available, which include the guide wire. Sterile precautions should always be taken. And for central arterial cannulation, full barrier precaution like caps and eye protection should be used. In case we are cannulating unconscious patients like prior to pheochromocytoma induction, local are used. There are two approaches: direct puncture of the vessel and the use of the guide wire. Guide wire is especially used if the difficulties with direct puncture is there, and ultrasound use is coming up in a large way. For all the approaches to the arterial catheterization, the operator's non-dominant hand gently palpates the artery, while the dominant hand manipulates the intravascular catheter. For the direct puncture approach, first starting with the 45-degree, entering into the vessel, and then reducing 30-degree and advancing slowly until the pulsatile blood return is obtained. The needle of the catheter unit is then slowly advanced another millimeter or two, assuring the blood return continues. This is the direct puncture technique. Whereas in guide wire technique, the needle has entered into the blood vessel, then a guide wire is inserted inside it, and the outer catheter is railroaded over the guide wire. Integral guide wire approach technique is also coming up. That is, the guide wire itself is within the set, that is, the specialized device is integrated with the needle and the catheter. Ultrasound technique improves first pass cannulation. As you can see, the transverse view of the ultrasound is taken, the radial artery is seen, and we locate the artery, the cannula is seen insert getting into the vessel, the angle is reduced, the catheter is threaded in to the vessel. Whenever using the ultrasound, it is always better to use the B mode and not the M mode to locate and cannulate the vessel. Using ultrasound decreases the complications like hematoma and embolism, and also increases the first attempt success rate. The IABP system consists of a transducer connected through a low compliant saline tubing to a 22 gauge cannula or 20 gauge cannula inserted into the artery. A bag of heparin, nice saline, pressurized to 300 millimeter is attached to the other end of the transducer and infuses saline through the system at 2 to 4 ml per hour to maintain the patency of the arterial cannula. Then the transducer is connected to the processor. The arterial, that's a pressure wave, transmits through the fluid column and vibrates the diaphragm of this transducer, which converts the electrical signal to be displayed on the monitor. It's based upon four principles: the sine wave, Fourier analysis, natural frequency, and damping coefficient. The arterial pressure wave consists of a fundamental wave, that's called the pulse rate, and a series of harmonic waves. These are the smaller waves whose frequencies are multiples of the fundamental waves. Example, if the fundamental frequency is 1 Hz, you would see harmonic waves of the frequency 2 Hz, 3 Hz, 4 Hz, and so on. So every material that has a frequency at which it oscillates, this is called its natural frequency. If a force with a similar frequency to the natural frequency is applied to the system, it will begin to oscillate at its maximum amplitude. And if the natural frequency of the IABP measured system lies close to the frequency of any of the wave component of the arterial waveform, then the system will resonate, causing excessive amplification and distortion of the signal. So that's called damping. So the natural frequency of the system especially increases when you decrease the length of the cannula or increase the diameter of the cannula. In other words, short, thick cannulas. Commercially available systems have the natural frequency of around 200 Hz, and we can decrease these natural frequency by using in between three-way valves and bubbles, clots. They can actually decrease the natural frequency. So anything that reduces the energy in an oscillating system will reduce the amplitude of the oscillation. However, some dampening is always required in the system. That's called critical damping. If it's excessive, the system is considered to be overdamped, or if it's insufficient, it's called underdamping. In an IABP, most damping is due to the friction in the fluid pathway. The damping is measured by a fast flush test. The dynamic response of the arterial line is testing using this fast flush test, where the transducer is briefly exposed to the pressure from the counter pressure bag by pulling the plunger. When the fast flush abruptly ends, the transducer system oscillates at its natural frequency. So this is the natural frequency which you see in here. Following a system flush, the amplitude ratio of the two consecutive resonant waves is obtained by ratio of the larger to the smaller wave. In a normal, this damping coefficient is around 0.7. In case this damping is more than 1, it is called the overdamped IABP. This system will not oscillate freely, and the details such as dichrotic notch will be lost. It will not overshoot, but will tend to underread the systolic blood pressure and overread the diastolic blood pressure. This is called the overdamped system. This trace is from the underdamped IABP system. Typically, the damping coefficient is less than 0.7. This system will be quick to respond, but will tend to overshoot and oscillate more around the resting point. So there will be overreading of the normal blood pressure, systolic blood pressure, and underreading of the diastolic pressure. This is what is called the optimally damped system. The damping coefficient is around 0.7, which provides the best balance between the speed of resonance and the accuracy. Whenever we have a lot of kinks or three-ways or bubbles in the system, you will find this overdamped system quite common, in that we flush the system and then we get a optimally damped system. Whereas underdamped system is seen in case we have a long tubing length, our tubing is connected with stopcocks, or in patient factors like tachycardia or high cardiac output states. So as you can see in this fast flush test, that for optimal system, we have 1 to 2 oscillations. Whereas for overdamped system, the oscillations will be lesser because the dampening is more. So there will be no ringing seen. Whereas for underdamped system, there will be excessive ringing, that is more than 2 oscillations. The intravascular pressure tracings obtained during this rapid flush of a monitoring catheter are frequently tested on exam. Then are the factors which affect the IBP measurement. That depends upon the site of catheterization, transducer level, damping of the pressure system. The site of the arterial catheterization, as you go away further from the aorta, you will find that the systolic peak becomes more taller. The dichrotic notch that starts shifting further. For example, in dorsalis pedis, the systolic is very high, whereas there is a shifting of the dichrotic notch. Whenever we are dealing with IVP, we should know about the phlebostatic axis, that is where the transducer should be placed. That is in the mid-axillary line and the fourth intercostal space junction. In the supine patient, pressure is measured from the right and left side of the arm by either technique will be same, whether you use non-invasive blood pressure or invasive blood pressure. However, in lateral decubitus position, you will find that the blood pressures vary by 20 centimeter different heights to 15 millimeter mercury pressure difference. That is, NIBP will be higher in the dependent right arm compared to the lower arm, like there are 20 centimeter difference, so you'll find 15 millimeter of mercury difference. In some of the cases, like in sitting position, the anesthesiologist may decide to level the transducer with the external auditory meatus to reflect the pressure at the circle of Willis and therefore the brain perfusion, which becomes really important in sitting positions. Coming to the interpretation of the arterial waveform, the arterial waveform results from the ejection of the blood from the left ventricle into the aorta during the systole, followed by a peripheral runoff during the diastole. The mean arterial pressure, this is the systolic peak, this is the diastolic blood pressure, and the mean arterial pressure is estimated by the sum of the diastolic blood pressure plus 1/3 of the pulse pressure. That is the difference between the systolic and the diastolic. Generally, the elevated pulse pressure indicates age-related stiffness, especially in hypertensive patients. Decrease in the pulse pressure relative to the baseline is typically seen in the hypovolemia. So pulse pressure variation can be used to assess intravascular volume status. The slope of the systolic upstroke is generally related to the left ventricular contractibility, and the slope of the diachrotic decline in the pressure, that is the diachrotic runoff, this runoff varies with the resistance in the arterial pressure. The stroke volume is constant, then the diastolic runoff decreases sharply. Example in vasodilator therapy. These are the abnormal waveforms. Pulses alternance is the alternating amplitude of the arterial pulse. It's commonly seen in heart failure due to left ventricular systolic dysfunction. This experience is characterized by two systolic peaks of the aortic pulse during left ventricular ejection, and it indicates aortic regurgitation. Less commonly seen causes are like Hawkins. A pulsus paradoxus is characterized by a greater than 10 mm decrease in the systolic arterial pressure during inspiration. It most commonly indicates conditions like cardiac tamponade, COPD, and constrictive pericarditis. The arterial waveform analysis can also be used for determining the fluid responsiveness. The stroke volume variation as estimated by the flow track or the Vigilio uses specialized transducers but uses arterial cannulas, A lines. Example is the EV1000, which is quite frequently used. The stroke volume variation, if it is less than 13, is what has to be targeted for the volume resuscitation, because the variation in the pulse is more with the respiration. That means the vessels are empty. Always remove air bubbles before you do arterial cannulation. Pressurize the system to 300 millimeter of mercury and heparinize saline at 2 to 4 ml per hour. Calibrate to 0 at phlebostatic axis. If the transducer goes by 10 centimeter lower than the phlebostatic axis, the pressure readings will be higher by 10 centimeter of water or 7.5 millimeter of mercury. And during shoulder surgery or beach chair, we monitor the cerebral circulation and place the transducer at the tragus level. There are complications of arterial cannulation like ischemia, hemorrhage, embolization, compartment syndrome. For the maintenance and removal of the A line, I-line catheters not to be replaced routinely. Femoral catheters not to be kept more than 5 days. All other A-lines not more than 7 days. Replace your transducer at the interval 96 hours and remove aseptically and give optimal pressure once you remove it. Coming to the next portion, that is the CVP monitoring. CVP gives us a representation of right atrial pressure and or the venous return to the heart, essentially the preload. One of the lumens of central line can be used to get CVP, and in a normally breathing, spontaneously breathing patient, it's around 5 to 10 centimeter of water, and it rises by 3 to 5 centimeter during mechanical ventilation. And whenever you do CVP monitoring, it's done at the end of the expiration. So whenever you be dealing with the central venous cannulation, it might be as a part of CVP monitoring, a PA catheter insertion, or transvenous spacing, or for hemodialysis. We use it for drug administration when we use vasoactive drugs, for TPN, for chemotherapy, for agents which are used for basically irritants to the peripheral lines. In major traumas, major surgeries, when we have risk of air emboli for the aspiration, and when we have inadequate peripheral IV access. A CVP waveform typically has 3 peaks, A, C, and V, and 2 descents, X and Y. You can remember A by atrial contraction, C by RV contraction or closed tricuspid valve, V, volume against the tricuspid. X and Y descents. The X descents indicates the atrial relaxation, and the Y descent indicates the AV valve opening. A wave does not have atrial contraction, so A wave is absent. Atrial flutter is chaotic atrial contraction, so multiple A waves are present. In complete AV block, you will find a large A wave. M-type pattern is seen as TR and pericardial tamponade. It indicates tall A and V waves. Multiple catheters are available which are used for CVP monitoring and infusion of the drugs. Introducer sheets with 1 or 2 integrated ports for multiple drug infusions are gaining popularity over time. These are the various sites, which includes IGV, subclavian, external jugular, femoral, and the peripheral PICC lines like basilic and cephalic. Whenever we have to select the site, always selecting the best site for safe and effective central venous cannulation should be made. It is basically dependent upon whether we are using for pressure monitoring versus drug or fluid administration, depending upon the patient's medical condition and the clinical setting. For more practical standards, IGV is the most common vein which is preferred in bleeding diathesis, emphysema, transvenous pacing. Whereas subclavian or femoral is a choice in trauma patients with the neck immobilized in a hard cervical collar, because you don't want to move the neck. And secondly, because the subclavian does not collapse in bleeding trauma patient because of the sheath around it, whereas the IGV collapses, and in case we are taking a blind access to the IGV, there are more chances of hitting the internal carotid artery. And we always need larger depth when we talk about either EGV or left-sided cannulations. These are the depths which are fairly fine, that is around 13 to 15 centimeter for the insertion. Left-sided would need definitely longer lengths. For dialysis catheter, right IGV is preferred to femoral, is preferred to left IGV, is preferred to subclavian. The catheters in the right IGV have a straighter course into the right brachiocephalic vein and the superior vena cava, and therefore are at least contact with the vessel wall. So catheter inserted through the subclavian or left IGV has one or more angulation, explaining the high risk of vessel contact and thereby thrombosis. Hence, they are not preferred when there is thrombosis risk. So avoid subclavian and RRT. Before, during, and after placement of the CVC, multiple practice guidelines have come up, which indicates the checklists. We have two approaches for the ultrasound: short axis and long axis. Short axis provides a better view in relation to the artery, but needle can be only visualized as an echogenic point, whereas for long axis, the entire needle course can be seen and it prevents the posterior vessel wall. Both have its own advantages and disadvantages. So the oblique view, that is a view which is halfway between the short axis and long axis view with the ultrasound probe placed at 45 degrees with respect to the vessel, can be used by experienced ultrasound users. The clinical pearls are that always use an ECG monitor, minimize the neck flexion and the head rotation. So consider removing pillows or towels behind the head to minimize the neck flexion, and position head approximately 40 degrees to the left. Extreme rotation of the head and extension of the neck should always be avoided. They tend to collapse the IJV. Avoid carotid artery in line with the advancing needle. So this can be done by using the markers on the screen. And whenever you're passing J wire through the catheter, don't use it more than 25 centimeter at the skin level. The ultrasound pearls are identify the anatomy and locate whether in the short axis as well as in the long axis, then confirm that the vessel is patent. Sometimes you have a thrombus in it. Use the real-time ultrasound guidance for the puncture. Oblique view is the preferred means. Confirm once you place the needle in the vein. Confirm the position of the guide wire once you place it inside, and even confirm the catheter once you place it inside. Always prepare the trays before inserting your CVP. Place the tray on the patient's chest so that you do not have to turn away from the patient to pick it up. Pre-flush your equipment. Close all your stopcocks and always get a chest x-ray. Avoid needle placement in the lateral 1/3 of the area between the clavicle and the mandible. Avoid carotid artery palpation because we tend to push the anatomy. Avoid carotid artery in line with the advancing needle in ultrasound. There are few complications. Pneumothorax is one of the most cited complication of the subclavian venous cannulation. Pneumothorax next. So multi-lumen catheters may carry a higher risk of catheter-related bloodstream infections. Heparin-bounded central venous catheters have also been shown to reduce the incidence of catheter-related thrombosis and infection in children and adults. The incorporation of antibiotic maybe silver or sulfadiazine or minocycline or rifampicin also came up in between, but did not gain popularity because of the more expensive nature of the catheters. The central line should always be confirmed by the chest x-ray, and it should be placed in such a manner the tip of the central cannula within this SVC at or above the level of carina used. So whenever you describe a chest x-ray, what's CVC, tell about the insertion site, whether it's an IJV or a subclavian. Assess the position by tracing it, whether it's too high or too low, like this one is too inserted or it is going into the other vessel like brachiocephalic, and the potential complications while describing the x-rays. CVP is the result of a complex and dispersed interplay among various physiological variables in the OR. So the use of CVP readings to estimate the cardiac function and blood volume rely on the fact that there is no ventricular disease or normal pulmonary vasculature, because isolated CVP measurements has little meaning unless information is interpreted in context of the cardiac function. Like if there is increase in cardiac function and venous return, both of cardiac output and CVP will increase. But if there is no increase in the venous return, you will find that the CVP is decreased, but still the cardiac output might be increased. So because of the complex interplay of the various factors, practically CVP losing its popularity. Studies have shown that the value of CVP as a predictor of volume status of fluid responsiveness have failed to demonstrate a relationship Single absolute value of CVP might not be lying in a fluid responsive zone, and we would not like to look for a single value. Trend may give you rough idea, but CVP is definitely losing its popularity now. Thank you. I'm open for question.
Do student have any question?
Sir, as of now, there are no questions in the chat box.
So we'll continue with the next session.
Yes, sir.
So next